Uh,
Good evening, everyone. Today, we are discussing an important issue in segmental anatomy, what would be called as the congenitally corrected transposition of great arteries. To the beginner, this condition is associated with a number of confusions and conundrums. It's my hope that at the end of this talk, you will be able to have a clear perspective of what is this condition, how do you diagnose it, and how do you manage it. Just as I go along, my request to you, I would just like you to send me a chat saying where each one of you are from, because some of the names in the list now I do not recognize. So I would very much like to know where you are from. So just send me a message on chat saying where you are from. With that, let us start. The atria are connected to the wrong ventricle. The ventricles are connected to the wrong great vessels. So there is an atrioventricular and ventriculo-arterial discordance, otherwise called double discordance. We will explain this and clarify this as we go along. The common term that is used is congenitally corrected transposition, or CCTGA. It's also known as L transposition because in situs solitus, the ventricular loop is L and the aorta is left and anterior. Because of that, the term LTGA is also used. But the obvious disadvantage of using the word LTGA is in situs inversus or in ambiguous situses, this is not the relationship of the great vessels, and the ventricular loop is not necessarily L. So perhaps an all-covering term would be congenitally corrected transposition. There's some history behind this. The first description was by the Baron Rokitansky, way behind in 1875. But like many such conditions, the actual clinical description and recognition of the clinical relevance was only in the 1960s by Schiebler. And the first repair had been attempted by Anderson and Lilly in 1957. But the surgical approach to this condition took a very significant upward swing when Igihara in Japan, Roger Mee, and others performed the first double switch. There are a number of people who are responsible for this in different places. And the idea that a senin-rastele could also be done where appropriate, and that would also constitute a double switch, came from Ilbavi in 1990. Let us look at this cartoon to understand what is the circulation in corrected transposition. On my left side, you have the normal circulation where the right atrium is connected to the anatomic right ventricle, which gives origin to the pulmonary artery. And on this side, the left atrium is connected to the anatomic or morphologic left ventricle, which gives origin to the aorta. Perfect. We don't have a problem there. In congenitally corrected transposition, the right atrium is connected to the morphologic left ventricle. And the morphologic left ventricle is giving origin to the pulmonary trunk. Now, it is an AV discordance because you can distinguish all the features of a morphologic left ventricle in the structure which is located as the lower chamber on the left side, but then it is connected to the aorta. It is connected to the pulmonary artery. Since it's a great vessel coming from a morphologically inappropriate ventricle, it is transposition. The great vessel, in this case, the pulmonary artery, is arising from an anatomically, morphologically wrong ventricle. So it is transposition. But since it is the pulmonary trunk which is arising from there. And since it is receiving only the systemic venous blood, it should be all right. That is why you call it congenitally corrected transposition. And on the other side, you have the anatomic right ventricle, which is giving origin to the aorta, and that is transposition. And that anatomic right ventricle is connected to the morphologic left atrium receiving the pulmonary veins. So it is AV discordance. And this is the double discordance, atrioventricular discordance and ventriculo-arterial discordance. Physiologically, there's nothing wrong in the circulation in this condition. So the morphologic right atrium, elaborating what I already told you, is connected via a mitral valve to the morphologic left ventricle. And this is connected to the pulmonary artery. Unlike the normal right ventricle, here the pulmonary valve is not sitting above an infundibulum. And indeed, there is a continuity between the pulmonary valve and the atrioventricular valve, that is a mitral valve. So there is a pulmonary mitral continuity. And the pulmonary valve itself is wedged between the atrial septum and the mitral valve. In this arrangement, the atrial septum is pushed away from the ventricular septum. They are in two different axes, and therefore the conduction tissue is abnormal. It is a longer abnormal course to reach its destination. Conduction tissue abnormality is inherent in this arrangement. If you look at this actual pathologic specimen, you can recognize the right atrium because of the right atrial appendage and because it is receiving the superior vena cava, if you like. And what is it connected to? It's connected to a smooth ventricle. And what is connecting it is a mitral valve. So this is the AV discordance. And from this left ventricle, you have the pulmonary trunk which is originating. So that is illustrated the major pathologic appearance of corrected transposition in the right heart. And if you remember the ventricular topology that we have discussed in the initial morphology classes, the Anderson's concept, if you keep your gloved right hand, in the normal D ventricular loop, your right hand, if you hold like this, your thumb will go into the inflow. It will go into the tricuspid valve, and your fingers will go into the outflow. You should be able to hold like this. The heart is in your hand. The thumb should go into the tricuspid valve, and the fingers should go into the outflow. This will happen only with a D ventricular loop. If it is an L ventricular loop, it is your left hand which will do this. So in the corrected transposition heart, the right hand will not go as illustrated in the image. Now what happens to the left heart? The morphologic left atrium is connected via a tricuspid AV valve to the morphologic right ventricle on the left side. So the left heart, in the upper part is left atrium, there is no problem, it is receiving pulmonary veins, but that left atrium pumps into a left ventricle, a left-sided ventricle, which is anatomically right ventricle. And the valve that connects it is the tricuspid valve. Much of the problems of congenitally corrected transposition stems from this arrangement. The great vessels are parallel. You know, normally the two vessels cross in the fetus. That's an important point that you recognize. The normal right ventricular outflow tract is sort of around the aorta. So the great vessels are crossing. This does not happen in corrected transposition, nor does it happen in proper transposition. They are parallel without the normal crossing of the outflow tract. And importantly, in situs solitus, the aortic valve is left and anterior. Left and anterior. They are side by side, but slightly anterior. In situs solitus, the aortic valve is left and anterior. What happens to the coronary arteries when the ventricles are inverted? they also get inverted. You could say that there is a concordance between the coronary arteries and their ventricles. They go with their ventricles. So if you, in cytosolitis, if you look at the right sinus, which is the anterior sinus, that would give origin to the left coronary artery, which would bifurcate into the LAD and circumflex. And your left sinus in cytosolitis, which is posterior, will give origin to the right coronary artery. So the coronaries come from the opposite sinuses because they are following their ventricles. So if you look at the pathology, look at the morphologic right ventricle here, which is all trabeculated, and it is receiving a tricuspid valve, and it is connected to the aorta, and below the aorta there is an infundibulum. The left heart is therefore described by all the features of the right ventricle, that there is a tricuspid valve, that there is a moderator band, that it is coarsely trabeculated, that it is giving origin to an aorta, not simply just giving origin to it, but above a muscular infundibulum. This is to show what happens to the coronary arteries. In this 3D reconstruction of a CT image, you can see the anterior sinus. The anterior sinus is giving origin to an LAD here and the circumflex here. And the posterior sinus is giving origin to the single coronary artery, which is going into the AV groove. We refer to the conduction system being sort of necessarily abnormal in corrected transposition. The sinus node is all right. But once you come to the AV nodes, there may be even two AV nodes. The normal AV node should be located at the apex of the Cox triangle. In corrected transposition, this is either not there or it is there without being connected to a His bundle. But the actual functional AV node is anterior, and it is beneath the opening of the right atrial appendage. It is at the lateral margin of the mitral pulmonary continuity, and therefore the conduction tissue is in direct relationship with the pulmonary valve. This is an important anatomic relationship in corrected transposition, that the conduction tissue is very close to the pulmonary valve. I'll illustrate this in a cartoon shortly. And the abnormal relationship between the atrial septum and the ventricular septum would distort the conduction axis. How? The His bundle is long. It descends on the anterior surface of the subpulmonary outflow tract on the right side. And it divides into a right bundle branch. The right bundle branch has now a long way to travel because it has to reach a left-sided ventricle. And the left bundle branch, which fans out into its fascicles, that is on the same side. When there is a VSD, a perimembranous VSD, the conduction tissue is anterosuperior to the VSD. Take some time looking at this picture. Look at the images here. You are speaking of the right-sided structures. This is the morphologic left ventricle. Imagine the morphologic right ventricle on the other side. The atrium is sort of missing here, but you can imagine you can see the aorta and the pulmonary trunk, the aorta being anterior and the pulmonary trunk posterior. And so this is where the pulmonary valve will come. My pointer is now on the pulmonary valve. The conduction tissue is descending sort of anterosuperior to that pulmonary valve. And when there is a perimembranous VSD, it's again anterosuperior to that perimembranous VSD. What are the segmental combinations that we would call as corrected transposition? In fact, there are several, but I would just describe what happens in cytosolitis and what happens in situs inversus. The first two of these segmental sets, the first is normal. The RA is connected to RV, LA is connected to LV. In Van Prust notation, we would call it S, solitus, D, D ventricular loop, and D position of great vessels, aorta is to the right. This is normal. But in cytosolitis, if you have RA connected to LV and LA connected to RV, and the aorta is left and anterior, it is solitus, L ventricular loop, L relationship of great vessels. So it is SLL. This is corrected transposition. Similarly, in situs inversus, you know the normal. But in situs inversus, even though the atria are inverted, if the ventricles are not inverted, it becomes I, atria are inverted, D ventricular loop, ventricles did not invert, and the great vessels did not invert, D. That is corrected transposition. So in situs solitus and situs inversus, these are the segmental combinations that happen to describe corrected transposition. Why I said there are several, the different combinations are still possible, especially in heterotaxy and crisscross hearts and all, will introduce much more complicated combinations, which we will not go into now. It is so common to have associated lesions in corrected transposition. VSD happens in 80%, subpulmonary outflow obstruction in 40%, an abnormal left AV valve or the tricuspid valve in 90%. These are common things. The VSD, when present, is usually perimembranous, but other locations, multiple VSDs, they can also occur. What may be loosely called pulmonary stenosis is essentially a subpulmonary outflow obstruction on the right side. It's commonly multi-level, valvar, subvalvar. The subvalvar obstruction may be muscular or fibrous, quite often supravalvar also, because the main pulmonary artery is small. And the left AV valve is very frequently abnormal. It may be dysplastic with thick or abnormal valves. There may be an apical displacement of the septal and mural leaflets, thereby qualifying to be called as an Epstein's anomaly. But it is unusual for gross displacement of the septal leaflet to occur. And once there is a VSD, the AV valve, more often the mitral valve, more often the tricuspid valve, may straddle. We refer to the conduction system abnormality. So there is a figure for complete heart block and varying degrees of AV block. Complete heart block occurs in about 10% at birth, and then it keeps occurring at a rate of 2% per year. And by the time adulthood is attained, or if you take the entire lifespan, only 40% will be free of complete heart block. Why does this lesion occur? Like almost everything else in pediatric cardiology, we do not know the answer. We know that there is a recurrence risk of 2.6 to 5% reported by different authors. What happens in embryogenesis is, you know that the heart tube normally loops to the right. If it loops to the left, the outlet component from which the morphologic right ventricle should develop will be placed to the left of the developing left ventricle. That is how the anatomic right ventricle moves to the left side. It develops from the essential problem, is that the looping, instead of being D, it has looped to the left. So this has brought the developing right ventricle to the left of the developing left ventricle. And that is how the AV discordance occurs. If you look at the clinical presentation, it depends on associated lesion. And if there is no associated lesion, it's going to be like a normal baby and there wouldn't be any symptoms. But if there is a large VSD, you can expect cardiac failure in infancy, just like in VSD in the normal segmental anatomy. And if there is a VSD PS, you could get cyanosis depending on the severity of PS. And you could get a murmur very frequently. The murmur denotes either a VSD or a mild pulmonary stenosis. Again, using the word PS loosely. Left AV valve, that is tricuspid valve on the left side, regurgitation. You could have a balanced VSD PS saturating well. There is a significant gradient across the right-sided ventricle's outflow tract, but the child is fine. In older children and adults, those who have been so far all right may go into heart failure either because they have development of tricuspid regurgitation, the left AV valve regurgitation, or because the systemic ventricle on the left side, the right ventricle, which is now occupying the position of the systemic ventricle, can't cope with the demands of the systemic vascular resistance, and that is failing. These two often go together. Left AV valve regurgitation and systemic ventricular dysfunction go together. Complete heart block, we already said. You must also know that there is an association with WPW syndrome and recurrent SVT in these children. So when you examine the child, when you are looking for the situs and the cardiac position, that is variable. Situs inversus will be present in 5%. 25% have dextrocardia or mesocardia. Situs solitus dextrocardia anticipate corrected transposition. Situs inversus levocardia anticipate corrected transposition. These are the two segmental combinations where there is a very high association, so that you should proactively look for and establish or exclude the diagnosis of corrected transposition. Checking saturation, it will depend on what happens in the VSD-PS combination. The heart size could be enlarged if there is a large VSD or there is a left AV valve regurgitation or systemic ventricular dysfunction. And one characteristic auscultatory finding in a heart which is located in the normal position is a loud second sound in the pulmonary area. When you get a loud second sound in the pulmonary area, it may be palpable. You would normally think that it is a P2, and you would normally think that there is pulmonary hypertension. But in corrected transposition, all that it means is that your L post aorta is transmitting the aortic closure sound, the normal aortic closure sound, to your stethoscope. So the loud single second sound in the pulmonary area, if the heart is located in levocardia position, is only because of the normal location of the aortic valve in corrected transposition. In chest X-ray, look at the situs and the cardiac position. You can see a hump on the left heart border. I'll point this out in a second. And aortic knuckle and the pulmonary trunk are missing. Look at this. You find a hump on the left heart border. This may be a little higher than this. Otherwise, this X-ray is normal. This hump is a feature of the L post aorta. And see how it will appear in levocardia as well as dextrocardia. In levocardia, you will get your hump here. This is the hump that we are speaking of. This more meso, I must confess. And in dextrocardia, you get the hump on the right heart border. ECG, look for the situs. In other words, look for the P-wave morphology. Look for rhythm. Absence of a septal Q in V6 is characteristic. You can imagine the septal activation is inverted. Normally, the septal activation should be right to left. That is why you get an upright R in V1 and a Q in V6. Here, you get the absence of the septal Q in V6, and you get a small Q in V1. You may find Q waves in 3 and AVF and a left axis deviation, and look for any evidence of pre-excitation and AV block. Spend some time looking at this ECG. To begin with, this is complete heart block, because you can see that there are regular P waves which are unrelated to the QRS complex with a variable PR interval. So you're dealing with complete heart block, and you're dealing with a narrow QRS complete heart block. In this, since it is a narrow QRS complete heart block, now let us look at the morphology of the QRS complex. This is V1. You can see a Q in this V1. You can see the Q in V1, and come to V5, V6. There is no initial Q in V5, V6. What looks like this slurring is because the P wave is getting superimposed there. So here is the lack of the septal Q, and here is the presence of the Q in V1. Here the axis itself is normal, and there is complete heart block. The cornerstone in diagnosis, of course, from echo. In echo, like you would always do, go for the segmental anatomy sequentially. If you do proper sequential assessment of segmental anatomy, you'll have no problem in corrected transposition. So you'll start by noticing the situs and the segments from there on. Remember, situs solitus dextrocardia and situs inversus levocardia are very likely to be associated with corrected transposition. And how do you recognize the key factor for the diagnosis, the double discordance? Remember the defining features of RV and LV. RV will have a septal leaflet which is lower in position compared to the opposite septal leaflet. It will have a densely trabecular apical portion. It will have a moderator band. It has an infundibulum. Left ventricle is smoother. Its AV valve septal leaflet is higher. The other features we have discussed in different locations, in different times. So I'll just highlight these things. And so you must be able to recognize the anatomic features of the right ventricle and the left ventricle, and this will help you to recognize the double discordance. The septum, the ventricular septum, has a horizontal orientation, and you'll find that when you're taking the parasternal long axis view, you don't find the septum. That is because the orientation is horizontal. And in the apical four-chamber view, you readily see the septum. And once you are looking at the great vessels, they are lying side by side with aorta left and anterior in situs solitus. The coronaries are inverted. You have to look for abnormalities of the coronary arteries, like a single coronary artery. In the days of the double switch, this has become important. Look for a VSD. Are there multiple VSDs? Look at the supplementary outflow carefully. Is there any obstruction there? Look at the left AV valve. Is it structurally normal? Is it leaking? Is there a straddling? Minor lesions like atrial septal defect may be there. There could be a subaortic obstruction like a subaortic membrane or a muscular obstruction. And look at the function of the systemic ventricle. So this is the difference between the normal and corrected transposition. In this 3D image, in normal, you can see that the mitral valve, the right ventricle is on the right side, the smoother ventricle is on the left side, and the AV valve offsetting is such that the left-sided valve is higher. As against this one, the right-sided valve is higher and the right-sided ventricle is coarsely trabecular. This again just correlating that with the four-chamber view on echocardiography. Not a great echo, it's a textbook picture. In the four-chamber view, you are noticing that your AV valve on the right side is higher. This is the AV valve on the right side, the septal leaflet, that is higher. And on the left side, it's lower. And there is more coarse trabeculation here. Today, alternate images like CT and MRI are increasingly used. This is particularly useful in older adults with TGA because the echo quality, what you are going to swear by the trabeculation and the offsetting, this may not be readily apparent. So the CT will tell you that the LA in this case is connected to the coarsely trabeculated morphologic right ventricle, which is on the left side, and the right atrium is connected to the morphologic left ventricle, which is smoother. And the coronary position also is nicely shown in this image. You can see that the left coronary artery is coming off the anterior sinus and the right coronary artery from the posterior sinus. This again another MR image. Look at the two atria above. They are labeled. Left atrium with the pulmonary veins here. It's connected to the right ventricle. Look at the thickness of the walls, while the right atrium is connected to the left ventricle. Look at the smoothness of the left ventricle. Should you catheterize corrected transposition? Only with limited indications. It is a characteristic catheter course which I would illustrate shortly. In complex corrected transposition, to evaluate for surgical repair, often it is required. And if an adult is undergoing a coronary surgery or a valve surgery, and if that person has a corrected transposition, you need a coronary angio. And you must remember that when you are manipulating your catheter across the RV outflow, you could cause a complete heart block. And generally, therefore, a balloon valvotomy is not done for a valva PS in corrected transposition. This isolated valva PS in corrected transposition is so uncommon. Quite often, it is associated with something else. So if you do a balloon valvotomy, you must be anticipating that there is a risk of AV block. I want you to look at this image. I hope you can see the movement of the image. Here, the venous catheter has come in through a inferior vena cava, which is located to the left of the spine. So you are dealing with situs inversus. The heart is on the right side, so it is situs inversus dextrocardia. So the venous catheter is coming from the spine to the left of the spine. It is entering the atrium. So you would presume that the left side of the atrium is the systemic venous atrium. And from the systemic venous atrium, you are entering a ventricle which is smooth walled. So this is the left ventricle. So you have demonstrated AV discordance. And what is it giving origin to? It is giving origin to a pulmonary artery. So this is the classic appearance of corrected transposition in situs inversus dextrocardia. Now look at the moving image once again. In addition to the morphologic feature, there is a tiny VSD. That's why the other ventricle is getting opacified. What happens to these patients? It depends on the associated lesions and the surgical approach. 10% of newborns with congenitally corrected transposition would have complete heart block. I already referred to the progressive occurrence at 2% per year as you're dealing with the older population. You find a larger number with complete heart block. There is a progressive systemic ventricular dysfunction and tricuspid regurgitation that occurs with age. And this generally tends to occur from the second decade and further. By 45 years, half the patients with associated lesions and a third of patients without any lesion have systemic ventricular dysfunction. And in the absence of associated lesions, there are sporadic case reports of survival to 7th and 8th decade. For women, pregnancy is well tolerated unless there is severe left AV valve regurgitation or a systemic ventricular dysfunction with an ejection fraction less than 40%. And these two instances would warrant counseling against pregnancy. Otherwise, they can tolerate pregnancy. Why does systemic ventricular dysfunction occur? The left ventricular myocytes are arranged in a particular way to promote generation of force most efficiently and to a much higher level than the right ventricle. They are counterwound helices that surround the ventricular cavity. So in systole, there is a peculiar torsional movement that generates much higher pressure and forces to sustain the demand on a systemic ventricle. This, once it moves to the right side, the purpose of this is lost. And the right ventricle, which is sitting facing the aorta, that fails by the time second decade or third decade is reached. And left AV valve regurgitation begins in second decade, and that definitely contributes to cardiac failure. A VSD in infancy is definitely a cause for cardiac failure. Today, quite often, corrected transposition is diagnosed in the prenatal period, and one would find it in evaluating fetal bradycardia, hydrops, or AV valve regurgitation. Bradycardia because of complete heart block, hydrops either because the complete heart block is associated with a very low heart rate, or AV valve regurgitation is severe and that is causing cardiac failure. And when this is being evaluated in the fetus, the AV valve offsetting and the moderator band are useful tools with which you can assess AV concordance, and also the fact that the great vessels do not cross. Now, how do we manage corrected transposition? Our approach to corrected transposition will depend on how the condition presents. Think of the newborn with congenitally corrected transposition. There is no structural lesion. Leave the baby alone, treat as a normal baby, and after the initial assessment, you can see them once in a year and look particularly for complete heart block. But supposing the newborn already has complete heart block, then you need to answer the question, does this baby require a pacemaker? Here you have ACC guidelines and European guidelines which say that it's a complete heart block along with a congenital heart disease with a rate less than 70 is an indication for pacemaker. Quite often, electrophysiologists tend to overlook this. Even if the rate is 60, if the child is normal, they may observe for a period before giving the child pacemaker to avoid pacemaker in the neonatal period. And many babies are unlikely to require pacemaker in the first few years, babies with complete heart block. But the standard recommendation is 70 per minute. If there is a large VSD, you need to close it either as a simple closure or with a double switch. We will explain that. And if it's a VSD-PS, if that is a balanced pulmonary blood flow, you just need to follow up. On the other hand, you have the options of sending diastole versus an LV to PA conduit. I'm going to explain these surgeries to you. Before that, medical management does have a role. In the neonate with severe cyanosis, prostaglandin may be indicated, or as an associated coarctation, prostaglandin may be indicated. And for the infant with large VSD, you need to give diuretics and captopril until you finalize on what is your surgical plan. And the adult with severe cardiac failure due to systemic AV valve regurgitation and the systemic ventricular dysfunction, the usual drugs that you would use like diuretics, ACE inhibitors, or ARBs and beta blockers. But you must remember that the treatment of this condition with these drugs is not particularly supported on robust clinical trial data. We are extrapolating our experience from treating the left ventricle in cardiac failure to the right ventricle. Whether it works the same way, we have no data. And I already referred to the pacing. Pacing guidelines for the asymptomatic patient are asked by the American College of Cardiology. And you may choose endocardial versus epicardial, depending on the size of the baby and the anatomy and what type of surgery the baby has had. And especially if it's a post-op complete heart block, if the physiologic repair has been done, it will be RV apical pacing, and after anatomic repair, it will be LV apical pacing. There is also some data on the use of resynchronization therapy for CCTGA with severe congestive heart failure. So the surgery will go in little detail. It may be simply to close a VSD. And if there is a VSD-PS, you may operate on it by opening up the outflow of the right-sided ventricle without using a conduit, or actually using a conduit when you may use a conduit between the anatomic left ventricle and the pulmonary artery. When it becomes a physiologic repair, you have still left behind the systemic ventricle as the RV as the systemic ventricle. You may make this a 1.5 ventricle repair. You have some concern about the ventricle's adequacy. Then take away the superior vena cava from that circuit, do a Glenn, and it will become a 1.5 ventricle repair. So surgery might involve surgery for the incompetent tricuspid valve on the left side. It may be a repair which may include an annuloplasty. More often it may be a replacement. And it may be a Fontan type surgery, which is obviously the case if one of the ventricles is hypoplastic, or there's a remote VSD, or there's a straddling. In the broader context of CTGA VSD-PS, what is the ideal surgery and whether Fontan will play a role there is some controversy. And then we have the anatomic correction, which is the double switch operation. So the surgical options summarized by Tom Carl, you could do a pulmonary artery band as definitive therapy for tricuspid regurgitation, or you could do in the neonate. I'll come to this in the next slide. So a PA band is one of the surgical options for a CTGA. You could do a classical or physiologic repair. You're closing a VST, you're not bothering about the segmental anatomy. You're doing a right-sided ventricle to PA conduit for a CTGA VST PS. These are the classic or the physiologic repair. You could do a sending with an arterial switch operation, which is the double switch operation. This I'll explain with a cartoon shortly. The reason why you do that, whatever else you do, you are leaving the anatomic right ventricle in the systemic position. If you want to avoid that, you have to do an arterial switch. And if you do an arterial switch, then to deliver the appropriate venous blood, you need a sending baffle. So that is why the double switch is a sending plus arterial switch. Also, if you are doing a Rastelli operation for CTGA VST PS, you can connect the anatomic right ventricle from the left side with a conduit to the pulmonary artery. And that has ensured the equivalent of arterial switch there. It is now the left ventricle is in the systemic position, provided you have done a sending. So sending Rastelli is the other way of doing a double switch. You could do it as a 1.5 ventricle, either physiologic or anatomic. Following a physiologic repair, if you add a Glenn, it becomes a 1.5 ventricle repair. Following an anatomic repair, if you want to add a Glenn, that becomes a 1.5 ventricle repair. Some surgeons prefer the root translocation, Nikaido. So Nikaido, along with an atrial switch, is also an anatomic repair. Nikaido is not very popular with arterial with corrected transposition because of the high risk of AV block. Fontaine operation we already discussed, and addressing the AV valve, the tricuspid valve repair, replacement, and in resynchronization therapy, the multi-site pacing to deal with systemic ventricular dysfunction. Many patients may not require a surgical treatment also. In this list, with one asterisk, we have indicated what is the systemic ventricle. The systemic right ventricle is with one asterisk, systemic left ventricle is with two, and if both are there, as in Fontaine, you have put 3 asterisks. This is a table by Tom Carl from an article published in Annals of Pediatric Cardiology. So this is the VST closure. I'm showing this only to show you where the conduction system is. The conduction system in the normal perimembranous VST is postero-inferior. In CTGA, it's antero-superior. This unexpected location, its long length, and the unusual location, as I said, that is what makes the occurrence of a complete heart block much higher following VST closure in CTGA. And this is the physiological repair for CTGA VST PS. This is the right-sided ventricle. You have just put a conduit from there to the pulmonary artery, as you would do in a routine TGA VST PS. The surgery is simpler, but it has left behind the systemic ventricle as right ventricle. And if you have a problem with the ventricle there, you could take the load off that ventricle by doing a Glenn. This is what is being done here. It's a Glenn along with a conduit repair, and so it has become a 1.5 ventricle physiological repair. So a Glenn is useful in the management of CCTGA because it could be the first stage in a planned Fontaine procedure, and it can support a small right-sided ventricle in physiologic repair. And if you're doing it in an anatomic repair, it reduces the complexity of the atrial baffle procedure because the surgeon needs to deal only with the IVC. The SVC is taken care of, so the baffle is simpler. In the baffle for the sending will be constituted only by the IVC. The SVC has gone to the Glenn. And some people believe that in the Senning-Rastelli combination, if you do it as a 1.5 ventricle, there may be an increased longevity of the conduit. I said we need to discuss PA banding. We need to band the PA if you want to prepare the ventricle for anatomic repair. Just as in late presenting DTGA, you would band the PA to train the left ventricle. If you want to do a double switch after infancy or in a situation where there is no large VSD or VSDPS, you need to train the ventricle. So then you put a PA band. It can also be a palliative procedure as a sort of definitive palliation, in the sense that if you put a PA band in a patient with CTGA, the right-sided ventricular pressure will increase, and you can determine how much you want it to go by. Normally you are targeting a 2/3 systemic RV pressure. That will shift the position of the septum to the midline. Otherwise, the anatomic when the anatomic right ventricle on the left side is pushing the septum into the left ventricle on the right side. So if the PA is banded, then the septum will stay in the midline. This midline position of the septum is a very advantageous thing for the CCTGA baby. It reduces the left AV valve regurgitation by itself. So if you are not doing anything else, if you just do a PA band, then also the left AV valve regurgitation tends to come down. There is an argument that every newborn could be given a little loose PA band so that the left ventricle will remain trained. This does not have universal takers. In presence of the dysfunction of right ventricle and tricuspid valve dysfunction, the pulmonary artery band is elevating the LV pressure. It is reducing the leftward septal shift and preventing further tricuspid annular dilatation, and therefore improving the stage of heart failure. I said even before going to the stage of anatomic correction, the band itself confers some benefits physiologically and clinically on the patient. Now let's look at the outcomes of some of these surgical techniques. When you do a conventional repair, the surgical risk is to the tune of 3 to 10%, and the 5-year survival is 75%, and 10-year survival is 68% from a large series that was published 10 years ago. And the incremental risk factors for death would be systemic ventricular dysfunction, left AV valve regurgitation, and AV block. Other than the survival, you are looking at the reoperation rate. This could be as high as 40% at 10 years. One, because of problems related to the left AV valve, and second, conduit change. And the problems of physiologic repair would be progressive left AV valve regurgitation, systemic ventricular dysfunction, the systemic ventricle is RV, AV block, not exactly because of the physiologic repair, but if you're closing a VSD or by the natural history, it can occur. And once there is a conduit, that conduit is going to degenerate. Now, anatomic repair, the logic is the conventional surgery leaves RV as a systemic ventricle. So in presence of a large VSD, a Senning arterial switch will achieve anatomic correction with VSD closure. In presence of severe left AV valve regurgitation, combined arterial switch and Senning operation brings the tricuspid valve to the venous side. You will need a PA band to train the left ventricle. And in CCTGA VSD NPS, who is otherwise a candidate for Rastelli operation, a Senning-Rastelli will achieve anatomic correction. It's not very clear whether this is long-term superiority over Fontan. And the best results for anatomic correction will be in the older infant with a large VSD. The ventricle is well prepared. You just need to do a double switch, and the child is old enough plus 6 months for doing a Senning. And also, if you have a 5 or 10-year-old child with CTGA, VSD, and PS, ventricle is well preserved. You're going to do a physiologic repair otherwise. If you can do an anatomic repair there, that will have a longer, better longevity. And anatomic repair is definitely preferred if there are balanced ventricles, good mitral valve function, the heart should be septatable, and the coronary anatomy should be favorable. These are the sort of caveats before you take up anatomic repair. But it's definitely preferred if there is a left AV valve regurgitation or if there is a systemic ventricular dysfunction to begin with, because these two entities are not going to do well if the right ventricle stays in the systemic circuit. And look at this cartoon. Here is the left ventricle. Now the arterial switch has been done. You can see the suture line. This is the aorta, and the RV is going to the pulmonary artery. You need this dog leg-like baffle to divert the vena cava blood to the right ventricle. And what are the problems of anatomic repair? It's a formidable surgery. So there's a lot of technical complexity and a learning curve associated with it. It is an uncommon lesion. So not many surgeons are comfortable in doing an anatomic repair. And it carries an operative mortality based on the surgeon's experience. Complete heart block can certainly occur. And we today recognize that the retrained ventricles may fail late in life. And the Boston group has suggested that if you do a PA band after the age of 2 years for training the ventricle, there is a greater chance of late heart failure in this group. You could have all the atrial baffle problems, baffle leaks, baffle obstruction, atrial arrhythmias. And in the cohorts with initially normal systemic ventricular function and initially normal tricuspid valve function, whether this actually gives a survival and quality of life benefit over the physiologic repair group is not fully established. And if you look at some of the anatomic repair outcomes, one of the best results are from the Birmingham group from Bill Brown in a large series of 113, which was published in the JTCVS. The early mortality varied between 1 and 5% depending on the actual anatomic substrate. And they noted that for the more complex ones, like with an arch repair, cardiac failure, neonatal age for surgery, the mortality was higher. But overall, the survival at 9 years was 90% with preserved LV function. And from freedom to reoperation at 9 years was 76%. In the Senning-Rasteli group, the François Lacourgue's textbook has given a German series where the 10-year survivals varied from 70 to 100%, and the 10-year event-free survival is 70 to 85%. And Fontan does have a role in CCTGA. It is definitely indicated when there is a large VST which is felt to be unsuitable for biventricular repair because of straddling, one ventricle being hypoplastic. But with the anatomically suitable for physiologic and anatomic repair, should you do Fontan in those patients? And long-term results, at least in some of them, are comparable to the anatomic repair. And therefore, it is not clear whether a strategy of electively giving Fontan to patients with anatomically appropriate ventricles and anatomy for the either a physiologic or an anatomic repair, whether it is correct, it's not fully established. And Tom Carl has also compared the various options, the physiologic repair, the anatomic repair, and the Fontan repair. If you take technical complexity, it is most for anatomic repair and least for Fontan repair. I'm not going to take you through this table completely. I want you to look at it yourself. And late mortality and morbidity is maximum for physiologic, less for anatomic. Similarly, for late functional disability, it is less for anatomic and Fontan. These are some of the key references for this topic. The Tom Carl's article on analysis in pediatric cardiology, I would strongly encourage you to read. Most Adams, you would definitely be reading. Some of the other references, particularly François Lacourgue's textbook on conotruncal anomalies, it deals with each of the surgical repairs in considerable detail. Thank you. I know it's a long and complex talk, but if you have any questions, I would be very happy to answer.